Dear Chairman, thank you for the invitation to participate in the European Bifurcation Club 2021. I'm Alfonso JURADO from La Paz University Hospital of Madrid. And the title of my presentation is Bifurcation Lesion Preparation with Rotashock in Bifurcation Lesions. I have taken the liberty to change a little bit the title, as we prefer the term Rotatripsy, as it was the term we used when we first described this technique. The clinical case is about a 74-year-old female with several comorbidities, diabetes, hypertension, lupus, previous renal transplantation, who was admitted in our hospital for a non-STEMI episode. The left ventricle ejection fraction was 40%, and she suffered from peripheral artery disease, very severe artery disease with impossibility for radial or ulnar approach, and also with severe femoral disease. This is the first angiography with a calcified nodal distal left main and a critical lesion at proximal mid LAD that produced a TIMI2 flow. The patient was stable at this point. So in summary, we had two bifurcations in series, one at the distal left main with a calcium nodule, 100 of Medina, and the other one at the proximal mid LAD with some affection of the diagonal branch, 111 of Medina, but the diagonal branch had 1.52 millimeters of diameter. So we decided to perform the PCI without any left ventricle support because of the peripheral artery disease, with femoral approach, EBU 4-7 French, and we could cross with some difficulties to LAD with a cyan black wire over a fine cross microcatheter. However, the fine cross could not follow the wire, and we couldn't use it to exchange this wire and change for the rota wire. So we predilate with small balloons, and this is the angio after predilatation. We improved a little bit the flow, and we could observe better the calcium nodule at the distal left main protruding at this point, without significant impairment of the ostium of the left circumflex. So we follow with the initial strategy, the Rotatripsy, advancing the rota wire through the fine cross and performing a rotational atherectomy with a 1.5 bar. We knew that rotational atherectomy wouldn't be enough to ablate this calcium nodule, but it was necessary to deliver the shockwave balloon. So after rotational atherectomy, we used a 3.5 shockwave balloon, and we applied 80 pulses at distal left main and proximal LAD. Before these pulses, before lithotripsy, we protected the side branch, the circumflex, with another wire. That, as you know, is one of the advantages of the lithotripsy against rotational or orbital atherectomy. This is the IBUS after rotatripsy with some intimal ablations and deep fractures produced by rotablation and shockwave. And after that, we decided to post-dilate with a 3.5 NC balloon at height atmospheres. After that, we implanted two overlapped drug-eluting stents at distal, at left main and proximal LAD. And after that, we performed POT, an aggressive POT with a 4.5 millimeters balloon according to the measurements in the IBUS. This is the final result in the angiogram. And this is the measurement in the IBUS with a 10 millimeter square area, minimal luminal area at the calcium nodule. So in summary, we think that rotatripsy, the combination of rotational atherectomy and intravascular lithotripsy is a great technique when you have severe lesions and deep calcium, because a rotational atherectomy is needed to create a tunnel after intimal ablation to deliver a shockwave balloon that cannot cross if the stenosis is very tight. And we know that rotational atherectomy cannot ablate deep calcium, that also only performs intimal ablation, and Shockwave does it. So this is how we reflect this combination of effects with intimal ablation of rotational atherectomy, as you can see here, and deep fractures of Shockwave. So this is, we have published the first series of this technique, and probably the take-home message is that when you have critical stenosis with deep calcium, probably this is the best choice for prepare the plaques. In addition, when we are facing a bifurcation, lithotripsy permits to protect side branches, especially when we are talking about the left main. So that's all. Thank you for your attention.